Well, first I'm going to ask, everybody has a rose, please stand up. And I gave a rose.
Oh.
Okay, this is our team besides Jody and I. Tracy Newell is missing. I hear she's on a trip. And then also our community advisors, Ashi and Mohammed. So I would like to say first, it is miraculous to see people change when they have choices. They open up like roses if they see that they can make a difference, and they do have value. So we were the team that worked with East Africans with diabetes at Riverside and Midway. And our aim was to improve the Ethiopian diabetes patient outcomes through enrollment in interpreters, staff, large group classes, small groups, and targeted case management. Our aim was to have 80% of everyone who participated have a baseline hemoglobin A1C above 8%, and a follow-up hemoglobin A1C would show a decrease of 0.3% within 6 months intervention. And 80% of participants who had hemoglobin A1C less than 8% and a follow-up hemoglobin A1C will maintain that within 6 months. Now, just for those of you who are not real medically in tune, hemoglobin A1C is the average blood sugar over time, 24 hours a day, over 3 months. So less than 8 would be an average of like 170, right? Or like it's less than 180. So that's where we want to get to. And then 7 is run around 150, 160, depending on the organization. Okay, so we have cheers. 83% of our patients received their goal, achieved their goal. So we're very happy about that. And 80% maintained.
That's really good.
Now, the original design, we really changed. We had a series of 3 classes, each lasting about 2 hours, staffed with 2 to 3 interpreters, and we had myself, or one time Jody did it when I wasn't available. Even with the death in the family, our team went on. RD, the dietitians, and Amber Pelcher, MTM pharmacist, all took turns teaching. Now, the one thing that before we go to this part is, what happened with us is it became an entire clinic culture. Riverside, it truly became the medical home. Like Jody, when we had that meeting, would you want to say anything about, when we all came together and talked about our experience? Okay, all right. Well, what we discovered and discussed was we all became passionate and immersed with East African culture, finding how we could make it their medical home. Fartoon, Tigga, Saeed, and the community advisors and the people were very helpful with that. But what happened is when people came to the door, the MOAs got excited, and they'd come get me. And they'd say, so-and-so is here, or this is happening. They're the nurses, the doctors, and we captured them same day. We had the lab excited. They came up to our last visit, group class, and did the lab draws for us right on site. We had pharmacy helping invite. People were going back to look at the poster that we had that I presented in our national convention for diabetes educators. And that's what really caught fire, is it became part of our everyday care. And that's exciting. So, in order to sustain, we need to change design. Food costs were subsidized by our department, and interpreter fees and reimbursement were subsidized by a sharing at work grant. And not all staff were able to bill for their services provided during class. Medicare and medical assistance, the way it's set up right now, and we all know that Congress really can't make a decision on anything, so we have limited amounts of hours that are provided per year for diabetes education. So then we went and got a sharing at work grant so we could even have the people come. So a new design needs to meet these criteria. One person at a clinic is identified to coordinate efforts, lead the team, keep a list of patients. In our case, that was it. I've made a patient list. I keep track of them at both clinics, and then coordinate. We all work together, getting people to the classes, working with the small group follow-up, RN action plan. The numbers of hours of classes and visit matches the number of available reimbursement models. I just talked about that. So if you're on straight MA or straight Medicare, is it 1 hour for medical assistant? Two. 2 and 2 for each? Yeah, okay. And attendance at classes is large enough for the patients with coverage to offset those without. The other thing we were thinking of is only light refreshments are offered in class to keep costs down, because we really did cater a nice big meal spread from the 2 restaurants in Cedar Riverside area. Okay. And a system is worked out with the lab to pull patients of class to draw their blood. One thing I've noticed is it really, really helps in a clinic to have the point of care hemoglobin A1C on site. I would have the staff nurse come, roomie nurse come right into the room when we were doing this project to get the hemoglobin A1C drawn. Then we had the lab right next door in a different room, because East Africans will say yes and leave the clinic. A lot of times they don't want their lab drawn. So then I found this pattern, so that's what we did to make it change. There is a on-site interpreter. I can't really emphasize enough the value of Amina, Fartoon, Saeed, Bombish, Tigist. Tigist was invaluable. We borrowed interpreters from regions, because when we were having a large class, it was important to have, and answering surveys and questions, we really needed a lot of interpreters that were partners with us and knew the patients. There's an easy way to refer patients to other team members, and someone responsible to make sure the referral is put into the EMR. When we were talking about that, we had a group meeting after this whole project to decide what worked, what didn't, how can we spread it. And what we realized is the one thing we didn't have is how do you get the person referred from me to the dietitian, to the PharmD, to the doctor, the action plan for an RN to help reteach or go over goals with them when they see the doctor. We did that consistently in our group. We have really integrated it into the care process. I would go out and talk to the RNs at each clinic, and they would have, I would go over the action plan, and when they came into the doctor visit, they spent 15 minutes going over what we had taught in the small group follow-up, and then they were a part of that, and we really did see phenomenal success with people improving. The country of origin is consistently documented in quick questions, and all team members ensure close follow-up and understand plan of care. Care, patient-centered, collaborative, involving the entire team. We talked about this before when I was going through the slides, but all members of our team were geared towards same-day capture or consistent outreach to patients. I can't emphasize that enough. What would happen is often in a visit, and we've been doing this for several years at Riverside, but we even emphasized it more during this project, is I am okay with being interrupted for a few minutes to go meet a new patient. Because if the doctor says, I want you to meet Carol Engelhardt, and she will help you with your diabetes, and then I spend 2 minutes saying hello to them, they'll go up to the front desk and make an appointment. When we weren't doing that, what happened was they didn't show up. The interpreter would help them make the appointment, but they didn't know who Carol Engelhardt was. So that became really...
I have to say something about this too, is that Carol developed a reputation because of all this. So out in the Ethiopian community, they're like, you have diabetes? You've got to go see Carol. That helps a lot.
It does, it does. We have that, and then why I didn't come this morning is one of our Ethiopian patients needed to come today, and it was the only time he could come. He actually started at Brooklyn Center and is still there for primary care and comes here. And he wants to thank all of Health Partners for helping him live a healthy life. And his part is right. He came here 3 years ago, and I hope I don't cry, but, and he said that if he was in Ethiopia, he doesn't know if they would have been able to help him. He doesn't know if they would be able to help him achieve the health he has now. And I have all sorts of releases signed with him, so I can tell you he's an intern at Boston Sci. He's in college. He's doing really well, and I'm so incredibly proud of him and all of us helping him. So, and that was why I wasn't here this morning. It was the only time he could see me, so I saw him first. So then the other part is we were talking to DNS, the MTM pharmacist, the dietitian, worked closely with the provider, our enrollment staff, so that smooth handoffs took place and patients built trust. Me, the diabetes nurse specialist, Amber was our MTM. The RDs were Becky Straub and Tracy Newell. We made ourselves accessible to the care team. And when we had that meeting where we all met together, I think what we all said is we had passion. If I could put ourselves in a map of the Horn of Africa, I could say we fully jumped in. And I think that was the key to success, is, you know, you really have to decide. I mean, look at me. I'm not a person of color, and I've lived in rural places most of my life. So when I came to Minneapolis, and this was my neighborhood, if I made an intention to try to find out what the difference was, what would work. So the spread we decided should be targeted to the clinics with a significant number of ethnic populations. Brooklyn Center, Specialty Center, St. Paul, Midway for Center National Health, others. Now we are doing a lot at Midway for Center National Health already. That's one of my clinics. The timeline, 8 months, and training plan needs to be developed. Tips for working with different cultures, some specifics to diabetes care. New patient educational tools that are simple, culturally and visually appropriate, specific to diabetes, heart health, and overall health. And I will tell you one thing that I found out working with the community advisors, the interpreters, and the patients themselves is they don't like pictures of body parts. So when I made an education sheet about keeping healthy kidneys, I showed a cloudy glass going to a clear glass. If I would have had organs and things, they would have not just shut me down or just put their mind someplace else. And so then when we showed, like, keeping healthy eyes, we showed an eye doctor looking at a patient, looking in the eyes, but not the eye itself. So then, new EPIC tools, referral order for ethnic class, scripting for interpreters for doing reminder calls. Now, without our interpreters, this would not have happened. And I'm going to repeat that again. Without the hard work of our interpreters, this would not have happened. And I think there was a little friendly competition, even though the Somali population was not a part of the group. We were doing Somali women's classes at the same time, between the Somali population and the Ethiopian population, to see who could get them to class. Yeah.
When I subbed for Carol for one class, we had, I think it was 3 interpreters in the class. So there was 1 or 2 patients who spoke Oromo. They had an interpreter over this side of the class, and then there were some that were Amharic, and they sat here. And so every time I would speak, you know, then I would wait for the Oromo interpreter to do their thing and the Amharic interpreter to do their thing. So it's an adjustment. You know, being the educator, you have to really learn, be patient, and there's several conversations going on in the class, but it was still effective.
Yes, and the most, with the Ethiopian, there's a lot, the number of Oromo is a much larger population, so we did combine them. That's one of the changes we made. Because we usually had probably only 2 or 3 Amharic, and then the rest of them were Oromo speaking. So, spread communication care team about reimbursement model, including hours, type of visit, number of visits, type of provider to schedule with, and planning steps in a written format. Getting all pieces together, that's potential challenges, and incorporating the collaborative work piece into the current workflow, Interpreters, care team training, DNSs, RDs, MTMs, Epic tools, lists, lab text, data collection.
And dot, dot, dot.
Yeah, it's a lot. Keeping program financially viable, adding this additional work to current workload. Let's face it, it was a lot of work. So that's